Yeah, I think now the meeting is being streamed. Got it.
I hope all of you have connected.
Yeah.
Yes. Warm greetings to all of you. I'm Dr. Vandana Sadananda. 5th of March is observed by the Indian Association of Conservative Dentistry and Endodontics as National Conservative Dentistry and Endodontics Day. The Department of Conservative Dentistry and Endodontics, A.B. Shetty Memorial Institute of Dental Sciences, Nitte deemed to be university, in association with the Indian Association of Conservative Dentistry and Endodontics and Association of Conservative Dentistry and Endodontics of Karnataka, decided to celebrate National Cons Endo Day 2022 in a befitting manner by organizing a continuing dental education program on management of obliterated canals and intercollegiate e-poster and essay competitions for the BDS and MDS students of the specialty. Professor Dr. Mitra N. Hegde, Vice Principal of ABS MIDS, Nitte DU, and the Secretary of ACE Karnataka, who has been rendering her valuable service in the field of conservative dentistry and endodontics, has taken initiative, along with the President of ACE Karnataka, Professor Dr. Rupa Nadik, and Professor Dr. Aditya Shetty, Treasurer of ACE Karnataka and HOD, ABS MIDS, in organizing this program. May I now call upon Professor Dr. Hegde to brief the participants regarding the purpose of the celebration.
Respected Chief Guest for the day, Professor Dr. Naseem Shah, ex-Chief, Center of Dental Education and Research, All India Institute of Medical Science, New Delhi. Resource person for the day, Dr. Ajay Logani, Head of the Department of Conservative Dentistry and Endodontics, Center of Dental Education and Research, All India Institute of Medical Science, New Delhi. Principal and Dean, Professor Dr. U.S. Krishnanayak, President, Association of Conservative Dentistry and Endodontics of Karnataka, Dr. Rupa Nadik, Dr. Aditya, Head of the Department, Dr. Vandana, the coordinator for this program, Dr. Darshana, Dr. Gaurish, Dr. Prashant, my senior and junior colleagues of the specialty, and my dear students. I wish you all a very good morning. National Cons Endo Day is celebrated on March 5th every year, and the aim of this program is to create awareness about the specialty and its scope. It is our pleasure to have a role model of our specialty as our chief guest today. Professor Dr. Naseem Shah, ex-Chief, Center of Dental Education and Research, All India Institute of Medical Science, New Delhi. Madam was my inspiration during my postgraduate time. I did my post-graduation between 90 to 92. And she was the founder, editor of the Journal of Endodontology those days. And when I went for the conference, I had an interaction with her. And that is the time when I had an inspiration to write the first article. And those days, the article had a review of 2 steps, which is to come through post. I remember having two reviews in 1992, and later on it got published. And it happens to be the first article of A.B. Shetty Memorial Institute of Dental Science. Madam, I still have those letters which you have posted with your review comments. In the last 30 years, I continued to publish and inspired my students, and we have reached 375 publications plus in my department, thanks to these inspiration from these role models. Madam has been to our institution a number of times, and because of this, her new innovation of Seal Bio, a non-obturation regeneration-based treatment, has been practiced in our institution. Thank you, Madam, for accepting our invitation for the inaugural address on the occasion of National Cons Endo Day Celebration 2022.
Thank you.
Professor Dr. Ajay Logani, Head of the Department, Conservative Dentistry and Endodontics, Center of Dental Education of Research, All India Institute of Medical Science, New Delhi. Thank you for your supporting us in all our programs, accepting to share your knowledge and experience with us. In the process of teaching and learning, it is a pleasure to work with you to learn the advances in the techniques of dentistry, in the process of learning and unlearning I also find it very comfortable to interact with you and learn from you. Thank you, Ajay, for accepting our invitation.
Thank you.
This day, we also have organized an essay competition and an e-poster presentation for the undergraduates and the postgraduate students. We have got a very good response for the same. I put on record the support of the principal and Dean, Professor Dr. U.S. Krishna Nayak, for this program. I thank each one of the faculty involved in conducting and judging this program. My colleagues in the college, Dr. Darshana, Dr. Aditya, Dr. Gaurish, and Dr. Vandana. My colleagues from Bangalore, Dr. Prashant from KLE Rental College, and Dr. Mahalakshmi from Mysore. My heartfelt gratitude to delegates, including faculties, postgraduates, and undergraduate students. And I should also say that it is not possible without the support of the president of our Association of Conservative Dentists and Endodontists of India, Dr. Rupa Nadik, who always encourages academic programs in our, I think it is a most active state group of IACDE, which continues to have academic programs for postgraduates, undergraduates, and also private practitioners. Thank you, Rupa, for all the support. Now I request the president of the Association of Conservative Dentistry and Endodontics, Karnataka, Dr. Rupa Nadik, to welcome the gathering.
Thank you, Mitra, for those nice words. A very good morning to one and all. It's indeed a pleasure. Welcome to all on today's celebration.
And then I will call you.
At the outset, for me to be welcoming
Rupa, we are not able to hear you.
I think, madam, we lost her connection, madam.
Okay.
Yes,
I think
madam.
we'll go ahead. Well, just 2 minutes.
She's back.
Yeah.
But we still can't hear her.
Rupa, we are not able to hear you. Unmute yourself. Unmute yourself. We can see you, but we are not able to hear you.
Okay.
Yes, fine. Perfect.
Dr. Nazim Shah, I would say, is a unique blend of being an excellent academician, astute clinician, and an able administrator, heading one of the most prestigious dental institutions of our country, All India Institute of Medical Sciences. My association with Madam has been more than 3 decades, and it is so gratifying to have her amidst us, although it is virtual. A very, very warm welcome to you, ma'am.
Thank you.
Welcome the speaker of the day, Dr. Ajay Nagani. Whenever I have had an interaction with this gentleman, I always appreciated his passion to endodontics and the out-of-the-box thinking. And no wonder he has grown so much, both in terms of knowledge and stature. A very, very hearty welcome to you, Ajay. Welcome to the dynamic secretary, Dr. Mitra, and her young, energetic entire team who are responsible and the brainchild for this wonderful program. So welcome to all fellow members of ACE Karnataka, as well as other members of dental fraternity. Last but not the least, I wish to welcome all the registered delegates. And it is so heartening to see such an overwhelming response from all over the country. I'm confident that you will all enjoy this learning experience and go home fully enriched. Finally, I wish to end with a quote from Dr. APJ Abdul Kalam: where there is righteousness in the heart, there is beauty in the character. Beauty in the character ushers harmony at home. Harmony at all homes leads to order in the nation. And whenever every nation is in order, there is peace in the entire world, which is certainly the need of the hour. So let's all wish and pray for this peace. Sarve jano sukhino bhavantu, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschid dukkha bhag bhavet. Thank you so much.
Thank you, Professor Dr. Rupa Nadik. Your contribution is always recognized and appreciated by one and all. I now call upon Professor Dr. Darshana Devadiga to introduce and request the guest of honor of today's program, Professor Dr. Naseem Shah, to deliver the inaugural address.
Morning, one and all. I am Dr. Darshana Devadiga, Professor in Department of Conservative Dentistry and Endodontics from A.B. Shetty Memorial Institute of Dental Sciences. And I have been given this honor to introduce a personality who needs no introduction herself. Our distinguished guest of honor for today, a senior woman endodontist, and recognition of her illustrious career, I would like to present a representation of her milestones of her career. She has had an illustrious career as an ex-head of Department of Conservative Dentistry and Endodontics and ex-chief of the Center for Dental Education and Research, CDER, at the All India Institute of Medical Sciences, New Delhi. She has had several feathers in her cap, beginning with as the founder member of the Indian Endodontic Society, the founder editor of Endodontology, which she continued to edit for an illustrious period of 16 long years. And she has also been the past president of Indian Endodontic Society, the Federation of Operative Dentistry of India, and Indian Society for Dental Research. Madam Naseem Shah has 170 research publications and has delivered scientific lectures in over 90 national and international conferences. She has done extensive work in the field of regenerative endodontics, and her innovation, the Seal Bio, a novel non-obturation regenerative technique of endodontic treatment for matured permanent teeth, has been rewarded the Australian patent in 2014 and USA 2015 award. Ma'am, we are so honored to have you amidst us, and it's our privilege to be able to listen to your inaugural address. Welcome once again, ma'am.
Yes, thank you very much. Good morning, everybody. Thank you, Darshana, for an excellent introduction. And I can't thank enough Dr. Rupa Nadik and Dr. Mitra Hegde for such kind words and for inviting me here. The President and Secretary, respectively, of ACE, Karnataka State Chapter of Indian Association of Conservative Dentists and Endodontists. And I would also like to thank Dr. Krishna Nayak, Principal and Dean of A.B. Shetty Memorial Institute of Dental Sciences, Nitte University. Thank you once and all. Today, I'm very happy to be amongst you all to celebrate this Cons Endo Day, which falls on 5th of March every year. This was started in 1982 by 5 stalwarts of the profession, and it was named as FODI, that is Federation of Operative Dentists of India. Why it was called operative dentist was because our specialty deals with so many operative procedures on teeth and roots and all that. So it was termed, and it was being recognized as operative dentistry. But lately, then in 2011, it was renamed as Indian Association for Indian Association for Conservative Dentistry and Endodontics. One of the founders was my teacher, Dr. V.M. Desai, at Government Dental College and Hospital, Mumbai. And on this occasion, I would like to pay my tribute to such a fine teacher and a great human being who did so much for our specialty. Now here, because it's addressing all the postgraduate teacher, I would like to compliment all the postgraduate students, the present as well as the future, for choosing this specialty for their postgraduate course. I think conservative dentistry and endodontics offers such a vast area for learning, as well as so many varied clinical procedures to perform. And it is very satisfying and fulfilling. Our specialty deals not only with restoration of form, function, and aesthetics of the dentition, but also ensures good health of the roots, that is the foundation of the teeth and its surrounding structures. So it is very, very gratifying. Recent advances in aesthetic dentistry has revolutionized the management of discolored, malposed, and malformed teeth, so that patient who gets the treatment can overcome negative self-image and it can boost their self-confidence. But apart from all this, the most important highlight of our specialty is that we can relieve severe agonizing pain of the patient. As you all know, that pain of acute pulpitis, irreversible pulpitis, is so severe that if immediate endodontic intervention is provided, the patient's pain is relieved, and in turn, the doctor earns a lot of goodwill of the patient. So remember that anytime anybody approaches you with pain, try to provide immediate help instead of just prescribing medicines or prescribing X-rays. Now, I would like to say that our specialty has seen tremendous progress in the past 3 decades, and this has become possible because of the advances in technology, material science, engineering, physics, etc., which has impacted our clinical practice of conservative dentistry and endodontics to a great deal. Few examples of these are rotary root canal instruments, magnification and illumination in the form of loops and microscopes, then lasers, ultrasounds, photoactivated disinfection, CAD/CAM, and CBCT. The list is very long and it will keep growing. Then emergence of regenerative endodontics in recent years, both for immature and mature teeth, has also changed the practice of endodontics to a great deal. Introduction of nanotechnology has led to great improvement in dental materials, which can give us very excellent results in our practice. And same is with biomimetic materials, which have been made available recently, which has impacted the practice as far as vital pulp therapy goes, or root resorption, or apical barrier technique, etc. So what I want to impress upon is that innovations will keep coming. The specialty will keep growing. So it is very, very important that we all keep abreast of the emerging knowledge. That means each one of us have to be a lifelong learner. If you don't keep learning, you are lagged behind. So it is important to renew your knowledge every now and then by attending all kind of conferences, workshops, etc., which is what we are witnessing today. And here I would like to say that we have no dearth of talent in our country. And I'm sure all you young postgraduate students out there, very bright, talented, and enthusiastic, if you seriously apply your mind and undertake gainful research topics, which can lead to innovation in technology or in any kind of medical or dental devices, which can simplify the procedure for the dentist and become cost effective or beneficial for the patient, it should be possible. So think of innovative research topics and take our country forward. Now, I would like to say that all these things, you have heard so many armamentarium and advances in technology, we can appreciate that our specialty mainly deals with good clinical skill and competence based on sound theoretical knowledge. But besides all this, what is required to be a good and successful professional, that is very important. There are certain soft skills that one has to keep in mind. So I'm quoting from this foundation course, which is prescribed by National Medical Commission for the new MBBS students entering the profession. It's called foundation course, and it describes professionalism is clinical competence, communication skills, and sound ethical practices. So I would urge all of you to please go through this document, which is available online, and it describes many other essential requisites which can shape an all-round personality of a medical or dental professional. So with these words, I welcome you all for this enlightening continuing education program, and I wish all of you a very happy Cons Endo Day today. Thank you.
Thank you, madam.
Thank you, Professor Dr. Naseem Shah. Professor Dr. U.S. Krishna Naik, the principal, could not be here today due to an urgent commitment. We acknowledge his support and encouragement to all our innovative and constructive programs. We are indeed honored and delighted to have in our midst Professor Dr. Ajay Logani. He will be delivering a lecture on management of obliterated canals. Participants, please note that you can post your queries in the live chat box, which will be addressed at the end of the session. Now, I request Professor Dr. Gaurishes to introduce the esteemed speaker and moderate this session.
Good morning, everyone. It's indeed an honor to introduce the speaker for today, Dr. Ajay Logani, who needs no introduction. In fact, he is a professor and head, Department of Conservative Dentistry and Endodontics, Center of Dental Education and Research, All India Institute of Medical Sciences. Sir has done his bachelor's degree in the year 1994 from Annamalai University, Tamil Nadu. He went on to complete his master's in Conservative Dentistry and Endodontics in the year 2000 from Dr. MGR University, Chennai. He has worked as a senior resident in the Department of Dental Surgery, Lady Hardinge's Medical College and Associated Hospitals from 2000 to 2003. Sir has more than 62 national and international publications to his credit, and he is a principal investigator for projects funded by AIMS, World Health Organization, Indian Council of Medical Research, and as well as Department of Biotechnology, Ministry of Science and Technology. Presently, his research area or the field of interest include dental trauma, artificial intelligence, and vital pulp therapy. Sir has been a member of Indian Association of Conservative Dentistry and Endodontics, that is IACDE, Indian Endodontic Society, Indian Society of Dental Research, and International Association of Dental Research. And he is an immediate past president of Indian Society of Dental Traumatology. I welcome you, sir.
Thank you. I am sharing my screen now, please.
Yes, sir.
Can you see it, please?
Yes, sir.
Okay. Madam, permission to start, please. Thank you. Can you hear me, please? Somebody will have to keep telling me. This is, I think, going to be a norm. If you can, if I break in between, maybe you have to inform me because I would not realize it's 9:30, so we are starting on time. Welcome. And at the onset, I have to acknowledge the three ladies who are exemplary examples of two traits in my mind when I was listening to all of them. One of them, there are iron ladies. And the second thing which I think about them is that they have defied aging. They are an example of reverse aging, if I may say, for all three of them. And that is how I would like to remember all of them. Professor Madam Naseem Shah, the chief guest for the day, my head for life. You would realize why I say that. It's for a simple reason that if this presentation would have been made by her sitting in her room and it would have been made by me in my room, we would have had few slides which would have probably been overlapping. You will see the thought process is almost the same, and I've gained that thought process from Madam. Madam Mitra Hegde has always been kind for these interactions, these academic interactions, which we have been doing on and off. And Madam President for ACE, Professor Madam Rupa Naidek, it's always been a pleasure, as you yourself said, that you've been missing out of action for a few years. We do realize the commitments you would been having for your family, but it is always a pleasure whenever you did come to AIMS and on the other platforms we have been meeting. The team, Aditya and everybody from Nitte, I am really, really grateful for for this invite on the 5th of March for the Cons Endo Day. As I was saying, we have very, very good memories about the entire team when we came across me and Madam Naseem in 2019 for a similar 2-day program. We had the best memories at that time. And this is what I was trying to emphasize, the thought process between Professor Naseem ma'am and me. I also wanted to tell the younger generation that why 5th of March is celebrated as Cons Endo Day. They must know that the Federation of Operative Dentistry was established on the 5th of March, and the name of Indian Association of Conservative Dentistry and Endodontics was christened in 2011. And Madam, the only thing which was different from my thought process was that this happened in Delhi, in the New Delhi conference in 2011, when, if I'm right, that the name was changed from FODI to the IACDE, which is the current name. So this is something which I also wanted to tell the younger generations. They must know the history. They must know the founder members of this organization. You saw something in both Madam and Mitra Hegde. She remembered Naseem ma'am, and Naseem ma'am remembered her mentor in her college. So that's the culture. We have to remember our seniors and what they have given us. This is the message to the next generation, I think, from my side. Thank you very much for the kind introduction. Yes, I proudly represent the All India Institute of Medical Sciences, where I work as a professor at the Center of Dental Education and Research in the Department of Conservative Dentistry and Endodontics. And our department proudly has been trying to train the postgraduates into higher skills, and the department has also been trying to publish its research. The department proudly also has come out with some etiquettes for webinars, because this is what had been happening for the last 2 years. And I would like to share these etiquettes of webinar, which our department has vetted, has based on research, and this is what we always try and follow in the webinars which we attend or which we give. I always tell everybody, be punctual. You did see that today also, that everybody was 10 minutes before. So forget 3 minutes, it was 10 minutes. This was what the discussion was going on. We always say that whenever you join a webinar, switch on your camera so that you can greet everybody. During the lecture, mute yourself off, and when the lecture ends, get your cameras on and your mics on if you need to have a discussion. This is research-based etiquette which we made, was that always try and listen to the seminar or a webinar sitting up position, because they've told us that there is better cognizance when you are sitting and hearing it, and not while you are lying down. These are the two major disturbances we felt were during the webinar from a feedback. One was the mobile phone and one was the eating thing. Both of them is something which we request everybody, that if you have your mobile phone, put it off, put it into the cupboard, and I'm sure everybody's finished with the breakfast. This is something which only Professor Naseem Shah is doing right now. So again, as I said, that there are certain things which I would be telling you, but Madam would be following them. Always try and listen to a webinar through headphones. They tell us that when you do have headphones like Madam has right now, the understanding goes better. And that is what is our understanding about webinars. For the students, listen to the webinar. It's not like a physical class where you can take the notes. we've understood that whenever a student tried taking notes, he misses on to the message, which is there on the webinar, and ends up getting more confused. So just try and take notes. If you have any queries which you would be wanting to ask your mentors, those are the only things which you need to be knowing. And this is something, don't sneak out, be your own monitor, as the next slide would say. Keep an online backup. We sometimes do have issues in webinars, as we were saying, in spite of the fact that COVID cases are going to be down, but this is going to be there. This platform is going to be there, hybrid platform. So always be your monitor, and don't try to sneak out during the webinar. It's for your benefit. As Madam Naseem said, that now you can hear your mentors at no cost. You don't have to pay for your ticket. You don't have to pay for your stay. The time is being saved, but make full use of these kind of CDE programs which are being organized for your benefit. This is for the presenter. Always end up with an emoji. If you like the webinar, single clap and thumbs up. If you really like it, then might as well have it twice what you have. And for me, my critic, if Madam stays throughout the seminar, I am sure that the seminar has gone well. So let's see, as far as emoji is concerned. Okay. It's very difficult to have Naseem ma'am for the full 45 minutes of the lecture, and she having that attention span and saying that whether it is ending up interesting or it's going in the wrong direction, we will know at the end of the seminar from ma'am's facial expressions, which I will keep a track on, madam. Let's change the track. Let's change the track and come to the topic which I am supposed to be speaking on. And this topic which I'm going to be speaking on is dental trauma. And we do realize dental trauma does not have any time. It can occur anytime, anywhere. We do have most of the patients getting up in the morning, going to the washroom and falling down anytime. Most unexpected. Pain in endodontics through irreversible pulpitis comes there. You know that you have a cavity and it's going to give you pain someday or the other, but that's not the case with dental trauma. This can occur anytime, anywhere. And believe me, each one of us has been seeing the cases of dental trauma, and we do realize anything can happen, right from a minor luxation injury to an X-articulation, that is avulsion. Anything can happen. And for me, I divide these consequences into immediate consequences of traumatic dental injury. And for me, that's pain and swelling. Most of the patients end up because of the trauma, have pain and swelling. Disfigurement, immediate disfigurement is definitely because of the laceration, the soft tissue injuries. Disfigurement is also an immediate consequence of a traumatic dental injury. Obviously, if the severity is more and you've lost the tooth, then that is also one of the immediate consequences of a traumatic dental injury, almost leading to a lot of psychological effect. We've seen patients who have lost tooth or teeth during a traumatic dental injury, not being able to smile without keeping a hand on their face. So these are some of the immediate consequences of traumatic dental injury. I'll take a gap here and tell you that each slide of mine is going to have a message. So please try and get the message across onto each slide. My slides are most of the time through a thought process, and that thought process sometimes becomes difficult to get it over an online platform, but I'll try my level best. I just told you that as far as dental trauma is concerned, it can occur anywhere, anytime. And there are some immediate consequences which I highlighted. And in my opinion, there are then the delayed consequences of traumatic dental injury. And these are usually occurring over years. They do not occur immediately. The ones which occur immediately, I told you, they occur within 24, 48, 72, 96 hours of the traumatic dental injuries. But these delayed consequences of traumatic injuries do not occur immediately. You only see the ill effects of that traumatic dental injury maybe some years or months later. One of them is open apex. If the injury occurs in a young patient, which most of the time it occurs, the tooth may lose this pulp vitality. And what you see over after a couple of years, maybe 14 at 15 years of age, when you take a radiograph, you would have an immature and an open apex. Sometimes these immature teeth are associated with large periapical lesions. And then when you dig into the history, the tooth had a history of some kind of a traumatic dental injury, maybe 8 to 10 years back, but the patient was asymptomatic. So this, in my opinion, is a delayed consequence of a traumatic dental injury. Similarly, if the trauma occurs to a primary tooth, and at that stage, nothing happens to the primary tooth, but when the permanent tooth erupts at the age of 7 and 8, do we see some enamel hypoplasia, Turner syndrome? And then do we realize that there would have been a traumatic dental injury to the primary teeth? Again, a delayed consequence of traumatic injury, in my opinion. Root resorption, it does not occur at the time of the injury, but sometimes takes up to 12 to 14 months if it is getting undiagnosed, and then only could you end up having an external inflammatory root resorption or an internal root resorption. Again, one of the delayed consequences. This, again, is something which we see very, very often as a delayed consequence of traumatic dental injuries, and that's narrowing of the canal, narrowing of the pulp canal space, actually, including the pulp chamber and the root canals. And this is what am I going to be talking about today, is the narrowing of the pulp canal space. Since it's a webinar specifically meant for postgraduates, this is something which I need to clear the air on. This particular delayed consequence of traumatic dental injury, that is narrowing of pulp canal space, is known by many terminologies, and these are not a very agreeable terminology to everybody. As you see, they are being called as metamorphosis, dystrophic, diffuse, calcific degenerations. As the slides would proceed, you would understand that each one of these terminologies is not the right terminology. Metamorphosis is actually change in the physical form and structure. You will understand by the end of this presentation that nothing of that sort is occurring. Dystrophy is actually a disorder in the organ or the tissue is getting wasted. Again, you would end up understanding that nothing of that sort is happening. Degeneration is obviously deterioration and loss of the function of that particular tissue. Again, nothing of that sort of is happening. And so these terminologies are no more acceptable. You must understand that terminologies, to know the right terminology is necessary because it is for communication. Maybe you are sitting in Mangalore, and if you get a case of something similar, and if you have to describe it to me, and if you're using a different terminology, maybe the communication doesn't get proper, maybe the diagnosis doesn't get proper. So you must know the right terminology as far as this late consequence of traumatic dental injury is concerned. And as far as the right terminology is concerned, at present, we call it either as pulp canal obliteration or pulp canal calcification. These are the two terminologies which are most acceptable, and the European Society, the American Association of Endodontics, and the godfather of traumatic dental injuries, Andreasen, all three of them, or the two societies and that individual, agree that the best term to describe this narrowing of pulp canal space is pulp canal obliteration. As far as Engel and again the American Association of Endodontics have also said that you can call this as pulp canal calcification. This is where Professor Naseem Shah comes back again to my mind, as I said, head for life, because she only told us, don't take everything what the white write. Use your own mind and see what is the best for you, interpret. And that is what, after we've been doing that, we've kept that thing in mind, what Madam said. Always take everything with a pinch of salt. Don't take everything what they write as gold. We got to think on our own process. So having said that, these 2 or 3 slides would tell us that what, in our opinion, would be the best definition. For us, this is the complete definition or the terminology, that is trauma-induced pulp canal obliteration. As I said, there are only 2 terminologies which are accepted now. One is the pulp canal obliteration and one is the pulp canal calcification. Majority of them call it as pulp canal obliteration. We would want to be called as trauma-induced pulp canal obliteration is what our thought process is. The definition again is from the American Association, and it's in the glossary of endodontic terms. And what I need to highlight here is what is being given in the red color. What is being given in the red color. Now, this is the terminology or the definition which is being given by the glossary of endodontics, and it says increased dentine production. And it says that it is an end process is a calcified canal. Again, Madam kicks in and told and made us remember that don't take every definition, what they have written, see what is the right definition, and that is what is in our mind. See what I have written in the green color. In our opinion, and we would prove this, the literature only tells us that it is not increased dentine production. It is actually hard tissue deposition, and it is not actually calcification which is occurring there. It's the obliteration. So the red is the, if you read the red words and complete the definition, then it's according to the glossary. If you read the green and complete the definition, it is according to my particular mindset after a discussion, after having understood the pathophysiology, which I would also try and discuss it with you. Etiology is very clear. It is traumatic dental injuries. It is traumatic dental injuries which result in pulp canal obliteration, and that is why we prefer to call it as trauma-induced pulp canal obliteration. Two types of traumatic injuries in particular. Any traumatic injury can cause pulp canal obliteration, but in specific two types. One is luxation injuries. Again, in luxation injuries, any type of luxation injury can cause pulp canal obliteration, but the incidence is highest when there is an extrusive luxation injury and a lateral luxation injury. These are the two type of luxation injuries where the chances of having pulp canal obliteration is highest. This is followed by teeth which have been reimplanted immediately after avulsion. As far as concussion and subluxation injuries are concerned, there are very less chances of pulp canal obliteration. So what to interpret from this? The interpretation is that pulp canal obliteration, that the severity of pulp canal obliteration is directly proportional to the severity of the luxation injury. I can interpret it this way because intrusion, extrusion, as well as the reimplanted teeth, all of them show a higher incidence of pulp canal obliteration. So that is the interpretation which you can keep, that the severity of pulp canal obliteration is directly proportional to the severity of the luxation injury. Another fact which you must understand here is that in addition to the severity of the luxation injury, the amount of pulp canal obliteration also depends upon the stage of root development. The immature teeth with open apex is more prone to develop pulp canal obliteration as compared to teeth with fully formed canals or fully formed roots. You will understand this process also when I would come down to the pathophysiology of luxation injuries. The second, I told you there are two injuries where pulp canal obliteration can occur. One was luxation injuries. I told you among the luxation injuries is the extrusive and the lateral, followed by reimplantation. The other traumatic injury where we do see across a lot of pulp canal obliteration is our root fractures. And these root fractures, you can see this one of our cases where there was a root fracture in the middle apical third, and you see the follow-up X-ray at 5 years, no treatment. But what you see is total pulp canal obliteration. And again, you would understand that this is almost like a defense mechanism of the pulp. When these kind of pulp canal obliterations are always seen in cases where the union of the fractured instruments, fractured segments are occurring due to deposition of the calcific tissue. As you know that most of the root fractures can heal by connective tissue deposition. It can occur because of connective and bone tissue. Granulation tissue deposition is considered failure, and calcific barrier, that is the deposition of dentine in that area for healing, is considered as the most favorable type of healing, and pulp canal obliteration is most of the times associated with the last type of favorable healing. But this is again a defense mechanism of the pulp, where we see such kinds of pulp canal obliteration. This is where you would understand that why we want to make some changes in the definition, and this is where you would understand that why immature teeth end up having more pulp canal obliteration. Basically, you have to understand that pulp canal obliteration is response to a severe trauma. So you do understand, again, I repeat that why I want it to be called as trauma-induced pulp canal obliteration and just not pulp canal obliteration. You also have to understand that luxation injury results in total or complete severance of the neurovascular supply. So depending on the severity of the injury, there would be either partial or complete severance of the neurovascular supply. And the pulp canal obliteration occurs when there is an attempt for re-establishment of the pulp neurovascular supply, that is an attempt to revascularization. Try and understand, again, as I said, sometimes becomes difficult to get the message across. You understand that the trauma, a luxation injury, causes some disruption of the neurovascular supply, and pulp canal obliteration will only occur when that neurovascular supply is trying to re-establish itself. That is, that some kind of revascularization is trying to re-establish that there. And at this stage, at the time when there is re-establishment of the neurovascular supply, or when the pulp is attempting to re-establish his blood supply, something happens. And that something which happens is, actually, they say that there is a loss to the kind of autonomic and or the sensory control of the pulp tissue, and that results in differentiation of cells, and that results in deposition of the heart tissue inside the canal. Now, that is where I said that when I put you in the red and the green words, it's not always dentine which is getting deposited there. It all depends on which pulp cells get kind of initiated at the time of revascularization. If it is an open apex, and if the apex is large, then there are good enough chances that you will have the PDL progenitor cells coming in, and then you would have some kind of connective tissue getting deposited there. If you have a larger, it's in the sense, if it's still an immature root, then there are chances then osteoblast would come in. So osteoblast or bone-like tissue is going to get deposited. There are chances then the odontoblast get ignited there, and osteodentine, dentine, or cementum. So get that message that the material which is getting deposited is never always dentine. It could be anything ranging from bone-like tissue to cementum, and hence in the definition where I said that it would be prudent to use hard tissue deposition rather than using a dentine deposition. And this exactly results in an uncontrolled hard tissue formation. I would prefer to use that word. And this hard tissue deposition, always remember, occurs from the coronal to the apical direction. This is something, knowledge, go see it yourself, that the pulp canal obliteration always occurs from the coronal, that is the pulp chamber of the anterior teeth, gets the obliteration first, and then it proceeds toward the narrowing of the canal space. So it's always coronal to apical direction, and this obliteration could be total or partial. That is, partial is that if it is only occurring in the pulp chamber and up to the towards the middle third of the root, or if there is a total pulp canal obliteration, that is the pulp chamber as well as the pulp canal space. In our experience and the literature tells us that it's usually the total pulp canal obliteration which we see. You would understand the reason for this is in the coming slides when we make the diagnosis. Why do we end up seeing most of the times total pulp canal obliteration, and why partial? It's not that partial does not occur, it's most of the time missed. And I'll tell you the reason why we do not end up seeing more patients with partial canal obliteration. Histology is again making us understand the same thing which I told you in the pathophysiology. It clearly says that it is not dentine always. It is somewhere osteoid tissue, osteocementum, dentine, and there are multifocal points. There are somewhere calcifications which are usually composed of these 2 or 3 types of ill-defined material. And the point which most of the histology studies says is that there is canal lumen always present. And that's where the axiom comes for pulp canal obliterated teeth, that radiographically absent, clinically present. Always remember this, that whether or you see or whether you don't see a canal on a radiograph, but there would always be a canal present clinically. This is based on our understanding of the histology, that whatever, even if it is complete obliteration on a radiograph, histologically there would be some canal, and that if you search with the right armamentarium, the clinically that canal would always be present. Some data on pulp canal obliteration. I've already told you that any traumatic injury can have this kind of narrowing of the canal. It is occurring more in young adults. Again, I've told you the understanding on this, because you have to understand that pulp canal obliteration occurs when there is an attempt for the pulp to revascularize after the injury has occurred. And the revascularization chances are maximum in young adults. So that is where we see that that's the reason why we see that pulp canal obliteration is seen majority of them in the younger adults. Obviously, the forward positioning of the maxillary teeth get them more prone to injuries, specifically luxation injuries, and that's the reason why we end up seeing these kind of radiographic pictures in such teeth. Usually this kind of pulp canal obliteration, I've already told you, is in my opinion a delayed consequence, and it occurs anything between 3 to 12 months. That's the time period which it takes for a pulp canal obliteration to start. 3 months you would see somewhere in the coronal half, that is in the pulp chamber. 12 months, 24 up to 5 years has been said that that's the amount of time. Nobody knows why there is a difference in time for one particular tooth, but that's what the consensus is. That's what our understanding is also, is there that if there is a luxation injury, what I understand is that depending on the severity of the dislocation of the tooth, that is of the extrusive or the lateral luxation, or the displacement of the coronal fragment in cases of root fractures. So that is what the speed of pulp canal obliteration is also directly proportional to the severity of injury. Always remember this. So if the injury is very severe, you're really looking at an early pulp canal obliteration, but these are only hindsight thoughts. Really, we do not know about it, but this is clearly understood by us that the speed is directly proportional to the severity, and maybe anything between 3 to 12 months is what you are looking at seeing. Clinical diagnosis is not a rocket science in pulp canal obliteration. Most of the times, this is the chief complaint of the patient. They do not have pain. That is the reason why we do not end up seeing partial pulp canal calcification, because most of the times the patient is asymptomatic and the yellowish discoloration does not occur till the pulp canal obliteration has extended quite very extensively. That is the only time we end up seeing yellowish discoloration, and it's quite very understood that why there is a yellowish discoloration as compared to the grayish or the pinkish, blackish discoloration which we see in conditions with pulp necrosis or internal resorption. In these cases, there is increased hard tissue deposition, in the pulp chamber, and that decreases the translucency of enamel, and that is why that yellowish hue is what is seen in pathognomic of pulp canal obliteration in such cases. As far as the percussion and palpation is concerned, you're really not looking at having any additional information as compared to a normal tooth. And the same thing goes for the pulp sensibility test. So usually we have in clinical diagnosis these two armamentariums. One is the pulp sensibility test and the percussion and the palpation. You're really not looking at screening anything out of these. As far as pulp sensibility tests are concerned, they do not have any reliability. They've always, maybe it the thermal test or the electric pulp test, either the response is diminished or there is no response. But having said that, for the postgraduates, this is an area of interest. This is an area of research where most of the understanding for pulp sensibility test is based on the very early articles. Really do not know. The sample size was limited in those articles. Maybe this is the time again to understand if there is any pulp sensibility test which can tell us, even in calcified or pulp canal obliterated teeth, specifically the role of CO2 as a cold test for seeing whether they would work better than EPT. But at present, if you compare the cold to the EPT, they say EPT is better, but in our experience, both of them would not give you any kind of conclusive decision. So really, you're only looking at a true adjunct, not looking at getting anything out of this. Radiographic diagnosis is this. So these are the only two things. The clinical diagnosis, most of the times you end up having a yellowish discoloration, and radiographic diagnosis is only to see whether it is a partial pulp canal obliteration or is it a complete canal obliteration, whether there is a PI PI score being given to that. Is there a radiolucency in the radiograph? So that's the only thing which you are really looking at a radiograph from. Obviously, the angulated X-rays again is quite very useful because it exactly tells you in one angle, as you can see in this one of our X-rays, maybe it's faintly seen, but if you take another angle, that gives you more hope that the canal is present, and maybe a total pulp canal obliteration, but faint canal being visible, and that is enough for you to locate it, because in such cases, as you would see, you would require the endodontic intervention to be done. As far as the use of CBCT is concerned, the European Society is very, very clear that yes, these kind of cases are candidates for CBCTs, and it exactly tells us in the spatial location. If we are looking at doing it as a freehand, which you would understand what I mean by freehand. If you're looking at locating the canals freehand, then you exactly know where you are heading. And obviously, if you're looking at doing guided endodontics, then CBCT becomes a mainstay. And for us, why do we take CBCTs? Sometimes you would understand that this becomes necessary. In calcified canals specifically, we are really looking at catching the periapical lesions early. So for early diagnosis of periapical lesions, in our opinion, also is maybe an indication for CBCT. For treatment planning, as I said, it tells us really where the canal calcification starts and how deep do we have to go. So it prepares us mentally. So I think that is also a very important indication. And obviously, if you're looking at a 3D endodontic guided management of this kind of case, then this becomes mandatory. Consensus is that if most of the cases, if you are having a partial canal obliteration, 2D is sufficient, because always remember that 3D, I have understood that is indicated, but still radiation hazards is there. So be very, very careful whenever you are looking at getting a 3D for a pulp canal obliteration. Message is clear that for pulp canal obliteration, which are partial, you do not need CBCTs. But yes, if it is total and if it is below the pulp chamber, so you would exactly know how deep to go. If you're using a free hand, and if you're obviously using a 3D imaging technique, then might as well get a CBCT scan. Take your own consensus decision, and in the best interest of the patient is what my message is for. The question which is there in the next 10 minutes, which I have to address 3 or 4 questions, is to treat or not to treat. It's $1 million question in these kind of cases, because majority of the patients are asymptomatic and aesthetic is their only concern. What brings most of these patients to your dental clinic is the yellowish discoloration, which they have seen growing over the last couple of years, but pain is most of the times not their symptoms. So for them, it's the aesthetic concern. And for us, this aesthetic concern can easily be addressed by vital bleaching. Believe me, not much documented in the literature, but our experience tells us that this is a very, very simplified, non-invasive way of managing such teeth. But obviously, it depends upon the degree of the yellowish hue which you are dealing with. This is one of the cases where you can see it's a total pulp canal obliteration with quite a bit of a 3 shade and 3 or 2, maximum 3 sessions of vital bleaching, hydrogen peroxide vital bleaching. You can get the shade down to A2. So the message here is most of the times the patients are asymptomatic. Aesthetic is their main concern. This aesthetic concern can be easily addressed by vital bleaching, hydrogen peroxide, but not always predictable. Always remember this. Sometimes more predictable, sometimes less predictable. The biggest disadvantage is that the bleaching procedure would need to be repeated at 8 to 9 months. It tends to reoccur. The yellowish discoloration in our experience tends to occur, but for the immediate relief becomes the simplest way. Obviously, veneers are the second option which you can do as far as this is concerned, and the veneers have an advantage that it can kind of mask the discoloration, and it leaves the palatal surface clean, that in case you would require the access opening to be done in there, this space is always available to be there. This in contrast to the full crowns where the space would not be there in case endodontic intervention is done. Full crowns should only be taken if the discoloration is very, very extensive, then only go ahead for full crowns. Otherwise, veneers with the advantages which I told you would always be better. This debate would always be there if within colleagues also, whether you want to do a prophylactic endodontic treatment, yes or no. Always base your answer on this. Remember that a pulp canal obliterated teeth, there are only 10% at the highest that the chances are that the pulp would undergo a degenerative or become non-vital and a periapical will develop. So it's just 10%. So that's the low chances of pulp necrosis developing. So you have to develop your understanding based on this data that there are very few chances that the pulp will undergo necrosis. So prophylactic endodontic treatment, the proponents of prophylactic endodontic treatment actually say that once the calcification starts, you must do the endo at that stage, because it would get complicated at a later stage in case the pulp becomes non-vital. But understand there are only 10% chances. And with the armamentarium which you have today, you can predictably do an endodontic treatment at that stage if required. So for me, the point of view is that you really do not require prophylactic endodontic treatment. So intervene only. Get this point very, very clear, that when the patient is symptomatic, that is, he has developed pain and swelling or both, that is the only time you're supposed to intervene, and intervene only if the patient has a radiographic PI score of greater than 3. So these are two scenarios. Patient is symptomatic, irrespective of the PI score, you have to intervene. But if there is an asymptomatic patient, and if you see a radiograph with a PI score of 3 or more, intervene in those cases also, because sooner or later this patient is going to experience pain. And why do you want to get that patient in pain when you can intervene right now? I think my message is clear. Hopefully it is clear. That is so. I've answered whether to treat or not to treat. The next question obviously is how to treat. The American Association of Endodontists tells us that these cases are classified under very high difficult cases, and that is what we are meant for. The question is to refer or not to refer. This is not a question for the endodontist. This is a question for the other referral specialities. It is a high difficult case. We are not looking at referring. Rather, the message to the postgraduates is that you have to develop an clinical acumen. You have to do cases where you would be able to negotiate these canals predictably. So referral is out of the question. Naseem ma'am said that may the technology come, but what is the mainstay is a clinical acumen, and it is something very, very important in such cases. You have to develop the clinical acumen, and in addition, you will have to select the right armamentarium. Magnification and ultrasonics are married in such cases again. And in addition, DG16 probe is the child hair. So you need these three things if you are really looking at managing such cases. The freehand technique is challenging, is because most of the times, even in a partial calcification, the pulp chamber is calcified. So what you do experience in a normal access opening for a central incisor, where you would feel a drop-off, these drop-off in natural non-calcified or non-obliterated pulp chambers tells you that you've reached the pulp chamber, and it tells you exactly it's the time to change your bird direction. But that does not happen in cases of calcified canals. So that is where you need to be careful. Do not expect any drop-off. Always prefer to do the access opening, initial access opening without rubber dam, because it helps you to tell you the orientation of the root, and always try and get the access opening through the incisal edge, because this is where you get the straight line access most often. Obviously, frequent radiographs. I always tell my residents that you need frequent radiographs. Anybody can go wrong. Orient your burrs, take frequent radiographs, and to know where exactly are you is what needs to be taken with angulated X-rays. Always remember from your anatomy that the pulp chamber is located at the center of the tooth at the level of the CJ. The pulp canal obliteration does not change that. So always orient yourself at the center of the tooth. This is where our experience little bit differs. We have seen that most of the times the orifice shifts slightly palatally because of the calcification, and most of the times we end up getting the canal palatally rather than in the center. But again, this is a personal observation. Majority of the people would say that it still remains in the center. We have our own understanding as far as this is concerned. We try and locate it a little more palatally than what it is. Under magnification, I hope this picture is clear. The canal orifice would be seen as a white spot, and that is because of the fact that the secondary dentine has a more whitened. So any calcification tissue which is getting deposited has a whitened appearance as compared to a darker color in and around. So that is where that is where you are looking at getting your canal. Once you get your white spot, you've got to make a purchase point, and this purchase point can be made with a DG16 Explorer. You've got to sink in. You'll have a sink in feeling. This is the softest part as compared as to the normal area. Once you have done that, you have to negotiate the canals. 2 or 3 minutes delay in my presentation. I think the message here is that you need to use K files, and in the K files also, with the negotiation should be done with the minimal size which you have. That's the 21 millimeter instead of 25 millimeters, because with smaller 21 millimeters length file, you can exert better pressure, which you require. The pressure is required at the end, which you cannot do it with a 25 millimeter. So always choose a K file in a 21 millimeter and alternate them between 8 to 10 size in a watch winding. This is extremely important. You give them more than watch winding, more than that, you're going to twist your file inside and fracture it. Be very careful. Alternate a 8 to 10, 21 millimeter file in a watch winding motion, and that is where you're looking at finding your canals, and most of the times quite predictably finding your canals. Once you find the canal, it's the crown down technique in which you are looking at preparing the canal. This is important for all the reasons which we know in there. If you don't use a crown down technique, there are chances that you would end up having kind of clogging again with the dentine debris, more in chances of pulp canal obliteration, so use it. Again, a very, very pertinent question, which we go wrong a lot of times. No need to actually use a chelating agent. Chelating agents are actually contraindicated during the search time. That's because that would cause the softening of dentine all around and increase the chances of perforation. So chelating agents are not recommended at all, specifically the liquid EDTA. The only thing which you can use is once you have identified the canal, once you have initially negotiated the canal, then EDTA gel can be used as a lubricant. My message is clear. If in case some people have a doubt, maybe later, because I need to finish. The enlargement is again, really, again, an opinion based. You don't need to go 3 times larger, specifically if the periapical is bare minimal. You can have it bare minimal preparation, but again, you must have it to the size of 35-40, because then the irrigation dynamics would only be active at that stage. Obturation is conventional. You're really not looking at doing anything. Freehand method does have problems. Obviously, gross destruction, gouging, you're trying to look like in this case, and perforations is always an issue as far as freehand is concerned. The way forward is 3D guided endodontics, and you do require a CBCT scan, surface scans for impressions, and then you superimpose and you get them 3D guided design and printing of a stint, and then you have it. Once you have this, you will have this flow, and you can easily, as one of our cases, as I show, can easily and predictably be done. A case of a total calcification with 3D aided guided is quite very helpful in such cases. We've also had done 3 or 4 cases, and we've had a link on this for anybody to see how is the workflow for 3D guided pulp canal obliteration case. So maybe you can visit this and see it for yourself. It's a self-explanatory video from the department. I would encourage everybody to see. Obviously, the advantages are immense. They say that there is minimal deviation as far as from the canal is concerned. When you do use this 3D guided, you can see the axis opening is absolutely straight, and it can be done by everybody. It has a very low learning curve. Freehand has a learning curve. You require the armamentarium of magnification and ultrasonics. Nothing needed here. So it has a big advantage. I think this particular technique is ideally suited for pulp canal obliterations. Obviously, once planned, you cannot change it, and you can only do it in anterior teeth. But most of the trauma-induced pulp canal obliteration occurs in anterior teeth, so we're really not looking at the posterior teeth. You can horribly go wrong, as we've understood over our cases again, but it all depends on the guides. So if your guide is fabricated properly, if your planning is done properly, then this technique does not fail you. But yes, if you have some glitches in the planning, then maybe sometimes you can go wrong, but that is also you learn with experience. So is there a new way forward? Yes, there is still a forward for such canals. No experience for us. I have seen Vivek Hegde doing a case with this. I would want more people to get into this. This is real-time navigation. We have a system in India now, and this is what you can exactly do. You can you just need a CBCT. The guide is not needed. There is real-time navigation, and you can see where exactly you are going and negotiate the canal. Just wanted to update the postgraduates that there is now this 3D navigation system. If you do get a hand on it, this is also one of the ways where you can get the canal obliteration there. As endodontists, we feel happiest when we recapitulate. We feel that the root canals have been done well. For me, it's always the presentation ends well. If I recapitulate, I told you that the right terminology is pulp canal obliteration or pulp canal calcification. Please just use these terminologies. I told you that the etiology is any injury but luxation injuries and root fractures. And among the luxation injuries is the intrusive and the extrusive and the lateral, which gets you more chances of pulp canal obliteration. I told you that the diagnosis is straightforward. Yellowish discoloration is the main thing. Only treat these teeth when the patient is symptomatic or a PI score is greater than 3. Otherwise, just do the aesthetic rehabilitation. A veneer, in my opinion, is the best. Bleaching, I told you the disadvantages. Crown, I personally feel, is a little more over than what is required. Freehand versus 3D guided endodontics. 3D is the more predictable method of managing such teeth, is what I would end up recapitulating, and the target messages across for you. The take office message. This is our logo for the department, which one of the postgraduates made, and it reads precision, perseverance, and perfection. I think these are the 3 attributes which would be required for managing pulp canal obliteration. So I thought I'll take a dual advantage of this thing, and that's my take office message, that you would require all these 3 things if you are looking at managing. I always end up with this, that trauma is something which you need to be treating emphatically with empathy. Discolored tooth or pain is always a problem for the patient. Always treat with empathy and don't leave half things. Emphatically means you've got to treat it completely. And all CDE programs should end up with this: benefit self, benefit patient. If you've got benefited by this, obviously somewhere or the other down the line, you would benefit your patients. So thank you very much. I think I'm down by 5 minutes, but I'm sorry for the delay. And thank you very much to the organizers and everybody for a patient listening, please. I'm done for today, please. Yes.
Thank you very much for this informative lecture, sir. We have some questions from the audience.
I need to come back to the video.
Yeah, we have some. Yeah, so yeah, screen sharing should be enough.
Can you see me?
Yes, sir.
Okay, I can't see anybody, so that's okay. I need to see madam.
Screen sharing.
Yeah, you can go for a screen sharing, sir.
No, my screen share is already there. I've actually hid the, yeah, I've got it.
Yeah, okay. Fine.
I've come back.
Fine.
Yeah, I'm back.
Yeah, there is a question asking, in the case of curved canals, as you said, the straight canals, we can negotiate with the 3D guided devices and things. In case of curved canals, if it's a posterior teeth or something, is it recommended to go for surgical approach directly?
No. So for posterior teeth with curved canals, you cannot do this, the guided endodontics. That's, as I told you, disadvantage. But I also went on to say that most of the times we do have trauma-induced pulp canal obliteration in the anterior teeth. We do not have it in the posterior teeth usually, but if in case you do have it in a posterior teeth, then obviously it's that 3D navigation now is where that role is coming, and that's where they are saying that that's the biggest advantage, that since it's not it does not have a guide, you can accommodate the handpiece and do it. So the ideal method would be to use the 3D guided endodontics, which is available in India now. But obviously, the practical one would be surgery if you can't negotiate the canal. And again, the message has to be clear. You only have to negotiate the canal if there is a periapical lesion or if the patient is symptomatic. Otherwise, it's natural obturation, if I may say. Why touch it if it is not there? Yeah.
Okay.
Thank you. Anything else, please?
So some of the cases, as you said, if you're not using a moon spur or similar device, is it advisable to use the ultrasonic tips from the middle third of the canal, or maybe to reach apex as well?
Yes, you can use ultrasonic tips in the freehand procedure. Obviously, the ultrasonic tips give you more controlled cutting and a better field of view, because the burrs, even if you end up using Mueller burrs or long shaft burrs, the field of view gets obstructed by the shaft. So maybe lesser, but as compared to a normal burr, but ultrasonics are best. And the only thing is the heat generation with ultrasonics. So you've got to use them very, very carefully. Intermittent cutting, but ultrasonic gives you the best controlled view and cutting, in my opinion, please. So ultrasonics would be what is recommended.
So in one of your slides, it was seen that PA index of 3.
Yeah.
The canal, in fact, in the 3D CT was not visible, but periapical radiolucency and some amount of root resorption or external resorption was evident.
Yes.
In such cases, do we really should try to do it or directly go ahead with the surgery, even in anterior teeth?
You see, you have to understand that the tenets of surgery say, this is my understanding. You see, I mean, my seniors are there and everybody, revered endodontist is there. So point of view, for me, the point of view is that the source of infection is the root canal. So if I may make you understand in very simple terms, the periapical radiolucency developed because of the source of infection being the canal. The surgery would no doubt curettage that periapical area, do an episectomy and seal it retrograde. But my understanding is that surgery is a technically demanding procedure and all portals of exit cannot be sealed predictably with a surgery and episectomy. So for me, I would always want to address the source of infection, that is the canal. And in this case, try and negotiate the canal rather than jumping directly into the surgical part. I hope I've got my message clear. It's thought process. It's a thought process. Always I've been saying it's a thought process. Maybe the thought processes differ, but that's my thought process, please. Yeah.
I think we are done with the questions.
Yes, thank you very much.
Yes, sir. Thank you. Thank you, sir.
Thank you.
Please note the e-poster competitions will be conducted for the postgraduate students on the 4th of March and for the undergraduate students on the 8th of March 2022 from 9 a.m. onwards. It is appropriate that we thank all those who have contributed to the success of this program. Many people have in one way or another rendered their helping hand, extended their services in varied ways. Now I request Professor Dr. Aditya Shetty to propose the vote of thanks.
Warm greetings to all. On behalf of the organizing team, I take this opportunity to propose the vote of thanks. I take immense pleasure in extending my sincere thanks to the guest of honor, Professor Dr. Naseem Shah, who kindly consented to inaugurate the program and delivered the inaugural address. Thank you for sparing your valuable time, Professor Dr. Ajay Logani. I extend my heartfelt gratitude to you for delivering the lecture on management of obliterated canals. The commendable lecture has enlightened us all. My sincere thanks to Professor Dr. Rupa Nadig, President of ACE Karnataka, for delivering the welcome address and for extending her support for all the activities of the association. I acknowledge the support of Professor Dr. U.S. Krishna Nayak, Principal and Dean, ABS MIDS, and the valuable contributions of Professor Dr. Mitra and Hegde, Vice Principal, ABS MIDS, and Secretary of ACE Karnataka. Thanks are also due to Professor Dr. Darshana Devadiga, Professor Dr. Gaurish S., Dr. Vandana, and my colleagues. I acknowledge the support rendered by the Staff Development Center of EKDU and the IT staff. Thank you.
Thank you once again for your active participation in the session. Have a wonderful day.
Thank you, madam. Thank you, Ajay. It was an excellent presentation.
Thank